So my presentation today is about AML, and I do, even though MDS is my research focus, I do take care of many patients with AML. I'm part of our leukemia program at Dana-Farber. And what I want to talk about is just some of the big changes in the last couple of years in how we treat patients with AML, how we evaluate patients with AML, and then some of the big challenges, particularly MRD. What do we do with measurable or minimal residual? Venetoclax fit in. That's available to us. I learned from Evandro last night. It's often available to you. How do we use it? We really are struggling with cytopenias and other complications. And then where are we going in the future? So the most recent data available, about 1 out of 4 adults will survive leukemia. I have 3 patients this month who relapsed 7 years or more out with the same original leukemia post-transplant. So it does happen, but most patients who get to 5 years will be cured. It will be interesting to see with the new drugs in the last 2 years, are they really going to move this forward, or is it only going to be a minor improvement? We shall see. Until 2 years ago, this was the decision tree for a patient. We meet the patient, we decide, is this patient a candidate for treatment at all? Because sometimes they're too old, they're too frail, just supportive care is best. And these 8 drugs have complicated it. How do we use these in combination? The NGS results help in some cases. 3 of these drugs are approved currently only in the relapse setting. That's the IDH inhibitors and gilteritinib, the newest FLT3 inhibitor. Now, they are moving into the frontline setting, but they're only approved now for relapse. That's the only data we have. Several are targeted, like midostaurin, of course, like gemtuzumab, but others are not so much. CPX351, it's just a new way of giving intensive therapy. One I'm not going to talk about is glastagib, this Notch hedgehog pathway inhibitor. We really don't know, first of all, are the combination with hypomethylating agents the same as low-dose cytarabine, which was what the FDA approved? And secondly, is there a unique patient group who benefits from this? So we don't know. We don't use it in our practice. We don't have it on formulary. So this one may be helpful in the future, but right now we don't know how to use it. I'll talk quite a bit about venetoclax. So that's what has changed things. Also, the availability of next-gen sequencing. 5 years ago, we were getting NPM1, we were getting FLT3, we were sometimes getting CEBPA, CEPBP alpha. That was it. And that helped us decide transplant, no transplant, high risk for recurrence or not. Now we get, a 95 gene panel, and almost every patient has a different pattern. So it's gotten much more complicated. And this has led to changes in our practice. Many of our doctors in the community in the past who were taking care of AML, they say, it's too complicated. We'll send them into Dana-Farber, we'll send them into Mass General. So we've seen an uptick in the number of patients we've seen because of the complexity. This is the sort of latest prognostic evaluation incorporating both traditional cytogenetics and the molecular genetics. You can see that this is from Ellie Papa-Manuel's New England Journal paper. The patients we have the most difficulty with are those with inversion 3 or abnormal chromosome 3q, very resistant to chemotherapy, and those with TP53 mutation, where they may respond to decitabine or azacitidine, but for a very short time, and then they relapse, and then we really have trouble. And there was a small but real survival advantage with midostaurin, and this was the first real positive survival study in AML in over 15 years, and so was very exciting in terms of moving things forward, even though only a small benefit. However, there are a number of other FLT3 inhibitors that are moving forward. Gilteritinib was just approved a few months ago by FDA based on this trial, the Admiral trial. This was in the relapsed setting or refractory setting, 371 patients. Patients either got gilteritinib, 120 milligrams daily, or they received whatever the doctor and the patient wanted for salvage chemotherapy, either low intensity with cytarabine or decitabine, or high intensity with MEC, which is the regimen we use, or FLAG-IDA, which is the regimen that MD Anderson and some other centers use. And then they were followed up. And the median survival was about 4 months better with the gilteritinib. The overall response rate was better. I view this drug primarily as a bridge to potentially a transplant if the patient hasn't been transplanted before, or a second transplant if they've been transplanted once before. Because alone, as monotherapy, the responses are not very durable. And there's some issues with transaminase elevation and things, occasionally QT prolongation, but it's a useful thing. Now, interestingly, FDA just reviewed the quizartinib study, which was very similar, but not quite as good, and FDA rejected quizartinib. So quizartinib's not dead. They have an upfront study. They're reanalyzing the data, etc., but it's not available now except on study. And then crenolanib is also moving forward. And so, we don't know what the approval is going to be for those two drugs. But the two we have now are gilteritinib and midostaurin, one approved for relapse, one approved for upfront. Now, CPX-351, this was the pivotal trial that led to its FDA approval. Notably, it was in patients with secondary AML who'd previously had MDS or therapy-related AML. And the patients had to be between age 60 and 75, which is a fairly narrow window, but many patients, of course, fit into that. It was a randomization to get CPX on days 1, 3, 5, could be repeated if day 14 bone marrow was positive, versus traditional 3 and 7 at the daunorubicin 60 milligram dose level. This, of course, is a liposomal nanoparticle, which is supposed to get better pharmacodynamics, and it is clearly different from 3 and 7. I'll talk about that in a moment. Do you have this available in Brazil at all? No? Not yet. It is an interesting drug. So this was the results of the study. The survival was superior with CPX compared to 3 and 7. We have used some of this. What we like about it is that you can start the induction as an outpatient. The patients tend not to get sick in the first 10 to 14 days. They seem to get less mucositis. Some of them get through the whole treatment without losing their hair because more of the drug goes to the bone marrow, less to other places. What we don't like about it is the counts take a long time to recover. It's at least an extra week and on average. And for some patients, it can be very long. I've had patients 60 days to recover their counts. I had one patient I treated with this. He had low-grade MDS for a long time, progressed to AML. We did this, and he did go into remission, but his hospitalization was so long, he refused transplant. He said, I can never go in the hospital again. Post-traumatic stress disorder. And he just couldn't do it. And so we gave him, supportive care, and eventually he relapsed and he wouldn't take any more treatment. So it's not easy in some respects in terms of the duration, but it is a little bit easier in that they tend to get less fevers, less mucositis. It's seems to be truly different. Now, one question about this is, do we have the dose right? And is 60 to 75, is that the only age group? We will use this sometimes because FDA didn't put a specific age on. If somebody is 55 and they have secondary AML, and we're going to treat them with intensive therapy. That being said, there's less data in these younger populations. So I think this is helpful, but it's a little step forward. It's not a major one. So what about MRD? We are getting MRD assays, but we're struggling with how to interpret and how to use this. One of the big questions, how to measure it. Is it better to do flow? Is it better to do NGS? Or do we always need to do both? What is the sensitivity? So flow assays have different sensitivities. We've had patients who are MRD positive, we can detect it, but it's at like 0.001% below the cutoffs used for most of the studies. Probably doesn't have the same implications as somebody who has MRD at 1.6%. When to measure it? Most of the studies have been done either at the end of consolidation or after several cycles of consolidation. However, sometimes we find in practice people are sending it like right at the end of induction, probably too early. How to interpret it, I talked about the percentages. That can be challenging. This is more difficult than ALL, and you really need, if you're going to use flow, a center that has really good flow expertise. We don't have very good flow. It's getting better. I shouldn't say that. Flow is not our expertise. We have tremendous genomics, but flow has lagged behind a little bit, so that's driven our practice. And then finally, what to do with the result. We know MRD is bad, but we don't necessarily know how to use it. If we transplant people because they're MRD positive, they still do bad. This is the largest study with a single gene MRD. This was from the MRC in the UK. They looked at over 300 patients who had nucleophosmin mutations. And they studied them in the blood, so blood versus marrow may not be the same, after the second cycle of chemotherapy, which sometimes was induction, one consolidation, sometimes was induction, reinduction. And you can see there was quite a difference in both overall survival and relapse for those who are MRD positive versus negative, but didn't seem to be much of a difference whether those patients got transplanted or not, if they were MRD positive. Secondly, there was this study from Hovon Sack that was in the New England Journal last year, and Ben Ebert and I wrote the commentary on that, because they found also that MRD was bad. It was worse if you had both flow and NGS positive, intermediate if you had one or the other. The exception was those mutations that are the common CHIP mutations, the big three, DNMT3A, TET2, ASXL1. If all the patient had was those mutations after induction and consolidation, then they did much better. And that's probably because these were people who had this low-grade clonal state. They had a outgrowth of AML, and then they sort of regressed back to that clonal state. Maybe long-term, there'll be an increased risk compared to people who have no mutations, but at least in the first 4 years of follow-up, the DNMT3A, the TET2, ASXL1 only did better. So here you can see this is relapse is going up here. It's the opposite of the usual Kaplan-Meier. The top one is if both were positive, the middle two, one or the other, the bottom, both negative. So, MRD is a very powerful predictor, but we are really struggling with what to do with it clinically. Well, many of our patients are older, and these patients present a particular challenge. We know that they don't do well with intensive chemotherapy because of comorbidities and poor response. The default is hypomethylating agent, but I have to say that's a pretty small improvement in survival, with the hypomethylating agents. Sometimes patients have a complete response, they become transfusion-free. That's helpful, but we need to do better. There was a lot of excitement and interest in 10-day decitabine, especially for p53 mutant disease. MD Anderson really likes this regimen. This study was done at WashU in St. Louis by Welch and colleagues and Tim Lay in Chicago. And they found that they had a very high complete response rate in MDS and a pretty good response rate in AML with TP53 mutations. But these responses were brief. The median was about 8 months. So we need to do better than this. Now, we have in vitro evidence that some myeloblasts are sensitive to BCL2 inhibition. Some others are not and are sensitive to MCL1 inhibition. I won't talk about that because those data aren't ready yet, but we may in the future do assays to see who will be sensitive to BCL2, who will be sensitive to MCL1, and add on venetoclax or an MCL1 inhibitor based on those results. I can envision that that's where we're going. Steve Strickland presented these data in venetoclax plus low-dose cytarabine for upfront AML, and it's a little easier to see here. These were patients who were over 60 who either were felt to be ineligible or declined intensive therapy. They could have had decitabine or azacitidine for prior MDS. The goal dose in this study was 600 milligrams of venetoclax, which, to be honest, we usually don't shoot for in clinical practice. We usually try to get to 400 if we can, and often we cannot. And you can see the overall complete response with incomplete or not was 54%, which is better than you would expect for low-dose cytarabine alone. Low-dose cytarabine alone, probably 15 to 20%. So, not a randomized study, but pretty significantly better. And you can see the patients who had prior HMA had a bit lower response rate than those who hadn't prior had HMA. Because we use so much HMA, the real interest has been in hypomethylating agent plus venetoclax. This was Courtney DiNardo's paper just showing very, very high response rate in terms of cytoreduction of the blasts. This study can see it a little bit better here. 71% complete response with incomplete heme recovery with AZA, 74 with decitabine. And, it tends to last for a while, 6 months to a year median response time, which is meaningful. So this has become our default regimen, our go-to regimen for the older patient with AML or the patient with P53 mutation who we think induction chemotherapy probably not going to have a good outcome. We are awaiting the randomized study. The randomized study has completed accrual in the US, but for whatever reason, there's also an Asian arm of it. That has taken longer to accrue, is still accruing. So we probably won't have the randomized data until next year. It's not going to be at ASH this year. So we're all very much waiting for the randomized. Meanwhile, everybody's using venetoclax. And so, I can see the sponsor probably isn't too... We're all going to feel really bad if that's a negative study because we've used so much of this. That being said, I think the likelihood it'll be positive is high, right? Fingers, toes crossed, all that. So, and it really, seems to be across risk groups. So even in the P53 population, which, is very resistant, response rate 65, 86% with decitabine. Our friends at MD Anderson have started, and I'm hoping to see an update at ASH this year. They've started combining 10-day decitabine with venetoclax. I imagine very much cytopenias will be a problem with that, right? But they're seeing a very high response rate, so we'll be eager to see this. We struggle as a practice, 5-day versus 10-day decitabine. We tend to use 10-day decitabine for either people whose disease seems to be progressing a little more rapidly, more proliferative disease, or for people with P53 who we're not going to give venetoclax to for whatever reason. Otherwise, there's some data that 5-day, 10-day are equivalent from MD Anderson, non-randomized data, but some retrospective data. So this is another unanswered question in AML. So in summary, we have just a couple more things to talk about relapse disease. This is our current approach. Still, the big question at the beginning is the patient a candidate for any therapy? Last month, I was on service. I saw an 88-year-old man who presented with gangrene of the toe. That was his initial presentation. He had, very high creatinine. And after discussion, they elected to go straight to hospice, straight to palliative care. And that's okay for a small, maybe 10% of patients. However, most patients want some therapy, and our decision is now more and more hypomethylating agent plus venetoclax for the older patient or the unfavorable genetics where we know that they're not going to do well with chemotherapy. Sometimes we'll actually follow that with a transplant if we can get them in remission, especially the lucky ones who get an MRD negative remission. Candidates for intensive therapy. Evandro wants to talk about NGS later, and I think that's great. We are fortunate in that for AML, we get the NGS back in 3 days. So most patients, we can temporize them long enough to make an informed decision. Are they a protocol candidate? What are we going to do if they're not a protocol candidate based on the NGS results? So that's helpful. And so we're still doing 3 and 7 for off study, but often with a targeted agent. Midostaurin if they're FLT3 positive because of the RATIFY trial. If they're core binding factor, we didn't talk about this, but that's where we're using gemtuzumab up front. We are also using it for CD33 positive relapse refractory disease, and some patients will do well with that for a while. Post-transplant really tough because of the hepatic risk, but and then again the same decision about favorable versus unfavorable risk genotype and trying to get them to transplant. For the unfavorable patients, for the TP53 mutants, we know that they do so poorly with transplant that when we do transplant, we preferentially do so on a study. For instance, we have 2 studies right now. One adds venetoclax to the conditioning and then has day 100 starting hypomethylating agent plus venetoclax. Very low dose because they don't tolerate it well from cytopenias. The second is an immunotherapy study. One arm has the GVAX, a vaccine that was developed at the FCI. Another arm is infusing natural killer cells after. So, we know that these patients, only about 15% of them are going to do well. So preferentially try to treat them on study. What do we do with the relapse patient? So traditionally, MEC or FLAG, IDA are the go-to regimens. If it has been a long time since their initial treatment, you could give them the same drug you gave them earlier, depending on their lifetime anthracycline dose. But now the targeted agents really come into play. So this is our group. We have 7 attending physicians and then some help from some of our scientific colleagues who are very nicely engaged.
Existem algumas evidências que talvez esses pacientes com essas mutações tenham algum benefício com o uso do venetoclax, né? Não somente os pacientes com P53. Você acha que é uma estratégia interessante nesse grupo de pacientes a gente oferecer até a gente ter a aprovação dessas drogas, nesse cenário dessa droga?
Yeah, I think that's a good question. So it's interesting that some of these agents that are not targeted have a high response rate in certain subgroups of patients. For instance, CPX351 actually has quite a high response rate in FLT3 mutant disease. So we've thought about, should we, nobody has combined yet CPX351 plus midostaurin. It was only with 3 and 7. So when we give CPX351 to a FLT3 patient, we're not adding midostaurin currently. In the future, maybe we'll have data. This is another example. IDH mutations, unless there's a concomitant RAS mutation, which seems to lead to inhibition, do seem to respond well to combination therapy with venetoclax, at least based on small numbers. So I think that's a very reasonable strategy for right now. I do hope that you get the IDH inhibitors, only because overall the response rate is not extremely high. The complete response rate is 18-19% for both IDH2 and IDH1. However, the individual patient can have tremendous benefit. And my longest patient was on the phase 1 study on the IDH1 inhibitor, and he was on for almost 4 years, complete remission after having 5 prior therapies, and ultimately died of influenza B. So even though he'd had vaccine, but anyway, so for the individual patient like that, it can be really quite helpful. And it's just that the majority don't respond. And so your strategy is perfectly fine.
David.
Yeah.
Working?
Yep.
Você consideraria venetoclax em outras situações de risco que não o TP53, para um paciente mais jovem, por exemplo, cariótipo monossômico, cariótipo complexo, onde a resposta com 7+3 é também muito baixa?
Yeah. So most, not all, but most of those patients with complex or monosomal karyotype have a P53 mutation. And that seems to be the driver of both the poor prognosis and the lack of chemoresponsiveness. In fact, if you look at the small subset who have complex karyotype who do not have TP53, they tend to be more like intermediate risk patients. They tend to do a little better. So it's largely driven by TP53, and that's a subset where we very much need new approaches, but where I think a venetoclax combination regimen is very appropriate, and that's usually what we use. If you don't have NGS, you could use the complex karyotype as a surrogate for high likelihood of P53. There are other drugs coming along for P53 mutant disease, like APR-246, for example, has been tested mostly in MDS. The French have a small AML study. You'll see some updates on that at ASH this year. Still very high response rate in high-risk MDS with TP53 with APR. It's maybe not as durable as we would like. Randomized trial ongoing with that as well. So that may be helpful for P53 mutant disease. We also are hoping to do a trial, hypomethylating agent plus venetoclax plus APR-246, which may potentially be synergistic or just may not be tolerated.
Bom dia. A paciente idosa com leucemia mieloide aguda que respondeu à decitabina por 8 meses, existe alguma expectativa de resposta fazendo o venetoclax com outro hipometilante, ou existe alguma evidência de que talvez seja melhor trocar por doses baixas de citarabina?
Yeah. So when the response rate to the hypomethylating agent venetoclax seems to be much better as initial therapy than in patients who have been treated with a hypomethylating agent alone and have lost response. The response rates are lower, probably because there's been additional clonal evolution. Nonetheless, because of lack of other good options, if the patient does not have a clinical trial, this is something we've been doing, is adding on venetoclax when they've lost response to hypomethylating agent. There's very little evidence that switching from one hypomethylating agent to another or to low-dose cytarabine is beneficial, and so typically don't do that.
Nós temos que fechar, we have to finish, por causa do tempo, mas o David vai estar disponível, não precisem ficar com vergonha, e super disponível para responder casos, simpático. David, thank you very much.
Thank you, Linda.
Vamos continuar.